Dear Chairman, ladies and gentlemen, colleagues, thank you very much for the opportunity to be here today and to present our analysis of midterm clinical outcomes and costs of robotic versus laparoscopic Roux-en-Y gastric bypass. How do I forward? Oh, all right. Disclosures. So from the literature, we know robotic Roux-en-Y gastric bypass is feasible. Literature shows overall comparable short-term outcomes when compared to laparoscopy. There is some short-term cost data out there with a degree of variability depending on the clinical outcomes that are underlying this data. Going into the midterm outcomes for robotic Roux-en-Y gastric bypass, limited availability in terms of clinical data. There are two independent meta-analyses showing a significantly lower gastrojejunal stricture rate when compared to laparoscopy. However, so far we have not found any midterm cost data. So the big question is, why do we want to look into midterm cost data for robotics? In brief, we are hoping to find a Cinderella story here. All of you know current surgical robotics with the Da Vinci surgical system come with a hefty price tag for capital costs, service, instrument, and accessories. Of course, Intuitive has a response to that. All of you might have seen this iceberg slide with admitting higher costs for instrument, accessory, capital, and OR time. But the argument here is with improved perioperative outcomes, you can balance those costs. However, if we take a step back and look at the case of gastric bypass, primary bypass is mainly a domain of minimally invasive surgery already. We lose a little bit the reduced length of stay. Conversion rate is extremely low in laparoscopic gastric bypasses, primary surgeries to note. It is hard to further reduce complications to an amount that we can balance off those costs, and in hand goes the admissions and the infection rates. So all that we are left with in that case is quite a financial heavyweight at the moment. However, this is of particular interest for certain healthcare environments. In Switzerland, since 2012, we're working with the diagnosis-related groups, or DRGs, which is a system that classifies hospital cases into one group, considering demographics, diagnosis, treatment, and complications. It was designed to replace cost-based reimbursement, and you get a flat fee of a one-time payment for 18 perioperative days, regardless of what approach you choose for your patient. Open, lab, robotic, all the same, no difference in reimbursement. The system is aimed to increase efficiency, basically thrown at the hospital. If you're too expensive, either find a way to get cheaper or maybe consider not doing that procedure anymore. Of course, if you use an expensive equipment like the Da Vinci surgical system, it is all at the expense of the healthcare provider, so the hospital has to swallow up those costs. However, should we have improvements in the mid or long-term follow-up, that would create windfall profits for the insurers, because same costs for the procedure, lower costs post-operatively, and here, in theory, we have our beautiful Cinderella, as it could be a rationale to negotiate a premium reimbursement for robotic surgery. So, coming back to the study, what did we do? In a single-center retrospective design, we looked at all our Da Vinci and laparoscopic gastric bypasses from 2007 to 2014 for clinical and cost outcomes beyond the perioperative period up to 5 years after surgery. Our cost analysis inpatient, we have a high accuracy itemized cost analysis. This data is also submitted for reimbursement calculations. Outpatient costs is based on billing data, which is not that accurate, and we have to assume a little bit of an underestimation here. For our surgical technique, both approaches standardized with a pouch of around 30 cc. In the laparoscopic cohort, circularly stapled gastrojejunal anastomosis, fully stapled jejunal anastomosis, elementary loop, both of 150 and 75 centimeters for the biliary loop, window closure at the surgeon's discretion. For the robotic technique, same cross anatomical structure of the bypass, We either chose a hybrid or total robotic approach. We had hand-sutured anastomosis, both for the gastrojejunal and totally 100% for the jejunal anastomosis. Again, window closure at the discretion of the operating surgeon. So what are our outcomes? Let's have a look. Demographic data, very similar, except for slightly more robotic patients with an ASA classification 3 or higher. Let's have a look at the effect of surgery between 31 days and 5 years. In regards to the comorbidity resolution, we have the comorbidity resolution that was documented. We have slightly better rates for hypertension for the robotic patients, but better rates for the laparoscopic patients in regards to dyslipidemia and GERD. The BMI follow-up clinically very similar, however, statistically significant lower BMIs for the laparoscopic patients year 1 to 3, similar outcomes for year 4, and higher BMIs for the lab cohort year 5. And now a bit more interesting, even more, our complications and hospital care. Very interestingly, we noted fewer internal hernias and fewer gastrojejunal strictures for our robotic cohorts up to 5 years after surgery. If you look at the second line, outpatient follow-up, these are our surgical, bariatric surgery-related follow-ups. We have some variability in terms of the number per year, but overall exactly the same or very similar for both cohorts. Now, if we are looking at the total number of ambulatory events and the total number of hospitalization days up to 5 years out of surgery, both significantly fewer for the robotic cohort. And now for the cost data, that goes hand in hand. We found differences for the inpatient treatment costs that were not statistically significant, though lower for the robotic cohort due to a higher standard deviation. But the outpatient costs were significantly lower in the robotic cohort. I have to mention some limitations of the study that are really important in interpreting the results. Number one, it's a retrospective design, chart review only, so we have a certain loss of follow-up, even though legally we have the obligation to follow all patients 5 years after surgery. We have a little bit of a bias in also the distribution of patients with a more aggressive transition towards robotic in the later cohort. And of course, we have to assume limitations in the documentation of parameters such as comorbidity resolution and complications. Overall, we can conclude that, again, clinical outcomes translate into costs, also in the midterm. We see some potential benefits in terms of clinical outcomes, going along the line also with previous meta-analysis, and cost benefits for the robotic approach, and that might serve as a decent baseline data for reimbursement negotiations. However, I must press the point that we need more systematic and higher quality data to make definite statements in regards to that. Thank you very much.